Well, good morning. Welcome to the first OPDAAC meeting of 2021. I think as folks join in, we'll get started with the introduction. I'm Alan Della Penna. I'm branch head for the Injury and Violence Prevention branch at the Division of Public Health and often host for these meetings. So appreciate everyone joining in. Just a little orientation. I want to thank the folks behind the scenes, Amy Patel and Margaret and Anna and some of the team are going to be handling the behind the scenes logistics. And we're really fortunate again to have the Governor's Institute for Substance Abuse that have been our partner in hosting these meetings since we've gone virtual. It's been a great partnership. If you've been through some of our meetings since we started virtual since September, we've evolved and I think we've gotten better at doing this. So I appreciate that. What we typically do is do a poll to see who's on the call. It kind of helps us understand the audience and who's among us today. So if you can just take a few minutes and click on the sector or the type of work that you feel is appropriate that describes what you do. If you don't see one that fits what you are, click other and put in the chat the sector or the discipline that you feel best represents you. We always try to make the OPDAACs as a group conversation, that it's not just a group of people talking to an audience. We're all learning from each other. The dialogue that we try to generate helps us all advance the work better. So during the meeting, you know, if we were at McKimmon Center, we'd have an open mic time and time for Q&A. I think most folks are used to the style of these webinars. We use the chat box. So as we go through the meeting today, please add any questions that come up, any ideas, any thoughts, put them in the chat box. Amy and Margaret will try to keep up with the chat and answer the questions. But as we get to the end of each speaker, if there's questions it would be better to ask the speaker to address, we'll have one of our team kind of raise the questions at the end. But that's really part of how we try to collaborate the learning and the work of the OPDAAC. We try to pick a theme. Our OPDAACs normally run quarterly. We're roughly trying to do these monthly, and we've had a slate of topics that we've covered throughout our virtual period of time. Racial equity is the theme that we're going to work on today. I think anyone who's working in the overdose and substance abuse arena realize race is a factor, and it cuts through a lot of the work that we do. So we have a panel of speakers, a selection of topics today from our partners out in the world that will hopefully help put a spotlight on the racial equity side of the work. This, as we go through the OPDAAC meetings, we try to select topics that come up from the participants or that seem relevant to address. And if you see a topic that you think would be good to spotlight and highlight on one of our calls, please add it in the chat or email it to us. I'll talk about this at the end of the meeting, but I'll talk about it now also, that we plan a meeting in March that will focus on pregnancy and parenting in the substance abuse arena. And then we have our big event, which is our every other year opioid summit in May, and some of these topics will be featured there. Okay, well, this gives a good example for our speakers of who's on the call today, so thank you. So our first presenter is Dr. Shuchin. How did I didn't do it real well. I did it okay. I used to think Della Penna was a tough name, and now I'm realizing it's a pretty easy one. Shuchin has been a presenter at our meetings in the past and has been a great resource and a partner for our work and out at MAHEC, out in the western end of the state. So without me mangling the introductions any further, I'll turn it over to Shuchin. Thank you.
Hey, thank you, Alan. Thanks, everyone. Good morning. I'm gonna, first, can someone give me a sign that you can hear me okay? And I think you could see me okay.
Everything looks good.
Perfect. I did a talk for the court reporters state conference, and they were really impressed with this headset, I guess, because they pay attention to audio quality as court reporters. So, so it's been really useful. So I'm going to share, and then can you guys see the screen? Should be the slides.
Very good.
Perfect. And Thank you, Alan. I can't see the chat box, so if someone has a question that they think I should stop and answer, please interrupt me. So in a little full disclosure here, I am on quarantine, my second of 3 weeks, and I have a 4-year-old here playing next to me, and she has promised to be good and not interrupt, but she might pop on the screen, and we're gonna roll with it. So as Alan said, my name is Shuchin Shukla. I am a family doc at MAHEC here in Asheville. And I've been in this equity work for a little while now. And so I thought it'd be helpful to kind of talk about how I got here as a way to frame how I think it's one way to have this conversation. I do a lot of presentations. I've done some for OPDAAC around either substance use disorders, done some for HIV, hepatitis C, transgender health. Those are sort of my clinical topics as faculty in our program. And I find equity the hardest. It's the hardest to prepare for, the hardest for me to deliver. It is a touchy subject. It's hard to do right. I know how to cure hep C. I know how to prevent death from overdose. I don't know how to address inequity. There's not great evidence of ways to teach this. And so we're learning this as we go. But I will say there's a couple ways I landed here. One is I'm a brown person growing up in outside New Orleans and born and raised there for many years. And so I have my own personal experience with the legacy of race issues in this country and being the son of immigrants and how that unique experiences played into my life. And so that's played a huge role in my abilities as a physician, as well as my abilities as someone working towards social justice and equity for everyone. And the other way is, the clinical work I do as a provider of HIV, hepatitis C, and substance use services. And some things I've learned from that is, one, and not, I'm 38 years old, another full disclosure, I haven't been on earth for that long, but in my brief time here, some of the learning I've been blessed to have through that work is that everyone has some secrets. Everyone has some stigmatized or shameful or maybe self-shame or outside of themselves shame experience or history. And so I'd ask you all, I think there's, I see 100 participants. I ask you all to just take a second and close your eyes maybe and think about the worst or most shameful, if you can use that word, thing you've ever done. And imagine I'm your doctor and you're coming into the hospital because you have shortness of breath. We think it's COVID, and I got a chart and I have your name and your date of birth. And for some reason in the chart, I have that one thing. And how would I treat you based on the worst thing you ever done? Because we all have that. We know, like it's in my slide, that 10% of Americans have an active substance use disorder. We know that 10% of Americans have used an illicit substance in the last 30 days. So if there's 100 of us on this call, I would assume 10 of us fit that criteria. So imagine if I was judging you as a doctor, I'm supposed to be someone helping you, but I'm also a position of power. If I were to judge you based on the worst thing you ever did, that would potentially complicate my management of your COVID. And then let's flip that to say I have your name and date of birth and I have the best thing you've ever done. That's all I know about you. It's in my chart. I don't know you otherwise. And how I would treat you then, because we've all had something that we're, maybe we keep skeletons in our closet, but we all have something we're really proud of what we've done or who we are. And so I kind of summarize that in a statement I like to say, which is at least to kind of ground myself, which is hard on principle, soft on people. And that we have a lot of feelings. We have a legacy in this country of inequity. And in some ways, we're all survivors of victimization, but we're all victimizers, whether we know it or not. And certainly in healthcare and in health, we know that harm you've experienced increases your chance of having health issues and maybe even having harm to others. And so there's got to be a way out. And I think one way out is having these conversations. So that's enough of my opening monologue. Let me make sure I can move slides here. So there's a ton of people at MAHEC and beyond that played a role in creating this content. This is a 30, hopefully 35-minute version. I promise, Anna, I'll do my best, but a short version of something that, this is a PhD, you could spend your lifetime studying and teaching this stuff. And certainly there's amazing organizations locally, regionally, and nationwide that do anti-racism workshops or work towards equity. So this is like a slimmed down version from a pretend expert, but it's based on the backs of all these great folks. And particularly I'd shout out to LaMercy St. Hilaire, who's a Duke Family Medicine faculty, who is sort of our expert in equity work. And then also Ana Cabello de la Garza, who really at MAHEC has pushed this topic to be front and center in MAHEC's work as well as in our work around opioid use disorder. So we're gonna, like I said, make this a slimmed down version of something that could be a lot longer, but we're gonna start with just some terminology and theory to kind of get a good vocabulary of how to talk about equity issues. Then we'll focus in on health disparities in the historical context of inequity, and then focus specifically on substance use disorders, and then treatment access. But you know, a lot of that is maybe doom and gloom, but we always want to end on actionable steps because there are things we can do as individuals and as a society. And it's great that I get to end on that note, because then the macro level steps are going to be taken on by our next speakers, who will be presenting from the Governor's Task Force on Inequity, and on racial equity. So I'm sure a lot of you have seen this little graphic. It's, I think, a great way to explain the difference between equality and equity. We often think of equality as really the thing that's enshrined in the Constitution or in Declaration of Independence or some of those documents. But you can see there, the equality is about treating each person equally, irregardless of their status or pre-existing situation. So you have three people and you have a barrier to seeing the baseball game, the fence, and you have equal sized boxes. And yet the tall person barely needed the box, and the shortest person gets no benefit from that box. You can leverage this to substance use disorders and saying, hey, if we gave everyone equal access to this, regardless of their situation, you have some people who will succeed in recovery and some people who will not. And if our goal is really community health, that's not going to work. So equity is a way of addressing that pre-existing situation in which each person is given what they need to succeed for whatever outcome. Here, the outcome is seeing the baseball game. For overdose, it would be survival, and not just survival, but thriving and succeeding in society with happiness and the ability to earn a living for your family, etc. Taking that a step further, liberation, you can see, takes away that barrier so that you don't have to worry about giving differential help. And so in substance use treatment, that might be changing the way we address the criminalization of substance use disorders, because that in itself is a barrier, or changing the way we prescribe opioids, or having universal health care, or more widespread access to health care. And then inclusion, here is, you know, the three are actually involved in the baseball game rather than spectators. In the substance use world, that could mean peers and people with lived experience having a seat at the table in terms of not only policy making, but how public money is spent and how rules and laws and regulations are made. So all that draws down to social determinants of health. And we've used this term a lot. We think of that as also as cultural determinants of health, structural determinants of health, social determinants of wellness. But basically, it's what we call these factors listed there that define and even predict someone's health. It's often said that a zip code is a better predictor of health than any other factor, because of how these social determinants are so hyperlocal. And so you can see there's a number of factors that come into this, but I think one misconception about this concept is that these are sort of like that fence in that previous graph. That's just some random barrier that we have to deal with. In fact, that fence was created by humans, and all these factors are actually man-made or man-controlled. You know, you could say, oh, it's just someone's luck if they have playgrounds or parks near where they live, or that they have access to healthy food in their neighborhood. But those are things we can change with policy, with funding decisions. And so these are things we do have control over to not only create health and wellness, but to really right wrongs from a historical legacy of inequity. When we drill down to how those social determinants of health affect specific populations, you can sort of see the usual suspects or usual groups that have faced historical inequity. So when we think of this in the lens of substance use and substance use healthcare, think about where each of these groups may or may not experience barriers to getting access to care, who gets incarcerated at what different levels compared to other groups. So we'll unpack that a little further. And one way to think about those different groups in kind of a next level way is the idea of intersectionality. And so if you think about your own personal selves, all of you who are listening in, we all maybe can define ourselves by class, race, and gender, and that and the social determinants of health can predict health and things like that, which is something I do as a physician. When I get a chart before I walk in the room, I'm already making some judgments, for better or for worse, about who I'm going to see and how I'm going to speak to the person in the brief time I have with them when I walk in the clinic exam room. But you can see there's a ton of other ways this plays out in a person's unique identity. And these aren't just social determinants of health that predict ill health. These are also factors in resilience. And so some of these, for instance, someone's gender or age or race or language can be both a hindrance or a barrier or a oppressive factor to health and healthcare, but can also be a source of resilience. And to be honest, if anyone's even like listening in or able to participate in anything, it's because of the survival and resilience of themselves and their ancestors. And so it's important to focus not only on the negative, but the positive of resilience, in that whatever adversity experienced by that person or those ancestors intergenerationally comes out through psychological hardiness, self-esteem, and community support that can result in a relatively positive outcome. And so we'll talk a little bit about social theory of how that plays out, but hopefully that gives you all a sense of some of the words and concepts of how we should think about equity and inequity in healthcare. So there's tons of examples, unfortunately, of inequity and disenfranchisement, and the ways healthcare and healthcare workers have worsened inequity through even recent US history. And so, this is a good opportunity to think about which of these topics are something you want to learn more about. And there's great, I would say, documentaries that go through these and great books written about each of these topics. But for the sake of our brief time, we're going to focus specifically on substance use disorders. But using, if you want to pick your favorite or least favorite, maybe, example here, one way to think about how this works intergenerationally rather than just a reality of the present generation is through intergenerational trauma. And I use this thought as a way of, when I hear people say, well, I wasn't involved in whatever trauma that resulted in this situation. I'm just here. I was born and I'm just a regular person. My family's immigrants too, as an Indian person of Indian background, I had nothing to do with the slave trade. Like why am I responsible for this? But one way to think of it is this mass trauma experience and how that passes through intergenerationally. And so usually this is defined as there's a dominant group. It doesn't have to be the one doing the domination, but a dominant group and a subjugated group. And that population experiences subjugation trauma in a variety of ways. It doesn't have to be just physical trauma. It could be segregation or displacement, which is often the experience of immigrants and Native American populations. Physical and psychological violence, which cuts across many different fields, certainly gender and sexual orientation. Economic destruction, again, plenty of examples. And then lastly, cultural dispossession, which is actually one of the most important because that's often the source of resilience for communities rather than just individuals. So then that first generation that gets that initial trauma experience will have a trauma response. And again, this may be a source of resilience, but it can also be detrimental in physical ways and psychological ways, as well as social ways. And so after that initial generation experiences that, some of that's encoded even in their biologic genes. And so we'll talk about that in a second. But subsequent generations experience that intergenerational trauma, as I said, genetic ways, environmental ways, in their hyperlocal communities. And that again points to those social determinants of health in terms of the built environment, psychosocial ways of how we interact with each other, and socioeconomic political ways in how societies are designed, and lastly, physiologic and legal ways. And that ends up with, again, these what we call social determinants of health, which are actually just a snapshot of how things are going now. But this framework helps build the story of how this connects to a long history of the people who survived or didn't survive before us. And so one way we talk about this specific to healthcare is ACEs. I'm sure many of you have heard of this, adverse childhood experiences. This has consistently been shown that kids that experience certain experiences, such as a parent incarcerated, or a divorce, or a family member who experiences physical or psychological violence, or if the child experiences that predicts a variety of poor health outcomes, including things like suicide, mental illness, and substance use. It's quite reliable. The more ACEs you have, the more likely you'll have these. Again, there's resilience, so this is not like someone's doomed to their fate, but it does statistically point out that there are ways to predict who's going to have a poor outcome and ways to prevent that if we prevent these ACEs. And in more of a social theory, that connects to isms, sexism, racism, ableism. And so there are ways to mitigate these risks, not just for children, but for future generations. But that trauma and those ACEs connect to actual biologic and chemical processes through epigenetics. And this might be a new topic for some of you. So I remember learning that, the genes you get are the genes you get, and they don't change. It takes, thousands and maybe millions of years of evolution for genes to actually change. We're seeing that now with COVID, right? But epigenetics are sort of the next level understanding of how genes work. And this is basically the simple way of saying it is like the on and off switch of how genes are expressed. And so though you might have the same genes that your parents had and their parents had and their parents had, whether those are on or off are changed day to day, lifetime to lifetime. And so in a variety of ways, whether just for risk of diabetes and mental illness, the experiences not only of you and your parents, but your grandparents will change your risk of disease or resilience. And so this is, I guess you could say the science, Western science, biologic flip side of that social theory of intergenerational trauma, that the things that happen to me are going to affect my 4-year-old and her future children, whether I want to or not. And so I think this is actually a point of hope that the things we do will actually change. There is a way to change and change the future of really our society and our country. So a pause, and I guess if it wasn't a pandemic and I had more of a live audience, I would ask the questions, but instead I'm just going to read it in the interest of time also. So true or false, many healthcare professionals believe in biologic differences between races. And I can't see the chat box. Maybe I'll pause for 20 seconds. People can venture a T or an F. So the answer is true. In a peer-reviewed article in 2016, 25% of medical residents, so these are doctors in training, they already have their degree, but they're still getting trained, believe that the skin of Black people is thicker than white people. 14% of second-year med students believe that nerve endings were different between races and that blood coagulates more quickly. This is crazy talk. It's not real. And this is not too long ago, right? And so there's a lot of work to be done to change the way we think. And I'm sure these residents and med students are well-meaning and well-intentioned. So this is not about blaming and shaming. This is about recognizing that we have some misconceptions and implicit biases that need to be recognized and eventually combated. True or false, 1 in 20 Americans, I guess I gave this away already, 1 in 20 Americans meets the criteria for substance use disorder. False, it's actually 1 in 10. And then lastly, true or false, white patients with pain are more likely to receive an opioid in the ER than patients of other races. True. Some differences there. And actually, I'll let you guys read the slide if you want, but it has actually been thought that, oh, that's why the opioid crisis has been worse for white populations more than non-white populations. But actually, it's been shown that for the non-white groups that experience racism, self-reported racism in healthcare, if they do receive an opioid, they're even more likely to have a substance use disorder. So there's no protective effect from this inequity of pain control. It actually having a non-white race increased your risk for substance use disorders. So it's a very nuanced situation. So I'm going to move on Hopefully I'm doing good on time, Alan. My clock says 10:24. So we're gonna move on to focus on substance use disorders and particularly opioid use disorders. So if you've heard me talk, you've probably seen this slide. We do this a lot at MAHEC. The US accounts for about 4% of the Earth's population, but we account for about 25% of overdose deaths worldwide. We're leading in that. It's the #1 cause of death for people under 50 who should not otherwise be dying in a wealthy nation as ours. It exceeds deaths from all those other causes, including others like HIV and hepatitis C. This is updated since yesterday, thanks to my team. From the Injury and Violence Prevention Center's data, you can see, oh, it cut off the slide a little bit, but if you could just take a look at the top right, that's 2019 compared to 2020 ER overdose visits, which is a little easier to study than actual overdose deaths, which have a more of a lag. But you can see the pandemic has not been kind, and in general throughout the state, we've been about 20 to 30% higher in our ER overdose rates. Right now in Buncombe, there is a rash of overdose in the last couple of days, actually, because of what's thought to be some contamination in the methamphetamine supply. So though we're not over the hill in any kind of way with the pandemic nor this opioid epidemic. Next slide again is busy, a lot of awesome stuff to look at here, but I ask your attention to the bottom right, which is one great way to address equity is healthcare access. So you can see self-pay uninsured patients per their compared to their population representation are overrepresented in opioid overdose ER visits, greatly so. If you compare that to Medicaid, which you would imagine is the same socioeconomic race, ethnicity levels as a self-pay uninsured, you can see a big difference. So we are providing care to the uninsured and taxpayers are paying for it. We're just paying for ER care. We're paying for law enforcement to act as healthcare workers when it'd be a lot easier if we just provided buprenorphine to people up front and paid for it so they didn't have to overdose and go to the ER. So hopefully soon. And then when we think about, if I go back to this slide, I'm sorry to keep going back and forth. If you look at the middle bottom, ER visits by race, ethnicity, though white populations account for most ER overdose visits and a little less than their population estimate, in fact, the acceleration of overdose deaths is worsening faster for non-white groups. And so worsening for everyone, we're all suffering here and we should all think of a solution that helps for everyone, but there would certainly be some community specific solutions that would be, that could be targeted to help those groups in more effective ways. So you can see for non-Hispanic Blacks and Hispanics, the increased rate per the CDC data in the last several years, they're happening faster than for the white population. Another example of inequity in substance use is the rates of incarceration. And again, I'm so happy to be on a stage with Steve and Jasmine, who are coming next to talk about the task force. But you can see a good place to start maybe is to think about the US population. Maybe you can see my arrow on the screen. White people account for the majority of the US population. You can see Black and Latinx population percentages there. And yet, despite that breakdown, 80% of federal prison and 60% of people in state prison for drug offenses are non-white. And so one might think, well, maybe it's because of differential rates of substance use. And luckily we have the data right here, which is from SAMHSA, showing that actually white people age 12 and over from 2018 data use substances at higher rates than Black and Latinx communities. And so this is really showing that if people are using drugs at basically the same rate, your risk of being incarcerated for using drugs is many-fold higher if you're non-white. And I have the utmost respect for law enforcement and the criminal justice system. Certainly if I needed help for my family, I would call 911 and ask for help and love the help I get. But at the same time, we know that jail is bad for health, and not just bad for health for the person incarcerated, for their kids and their future risks of healthcare issues as per those adverse childhood experience studies. And so here is an example of not only a failure to help folks with a medical problem with medical treatment, but also that we're worsening the problem for future generations to have substance use disorders. So we're not just ignoring the problem or not addressing the problem. We're actually creating new problems for the future. And then again, like incarcerating people is more expensive, not only less effective, but more expensive. You can see the dollars there. For every dollar you spend on addiction treatment, not even counting healthcare costs, you're saving $4 to $7 in costs related to crimes, the criminal justice system, the lawyers, the judge, the jail, all those things easily could be reinvested in communities or in other ways that law enforcement can be supported. Every law enforcement I've ever talked to who whatever their opinions of substance use treatment has agreed that they've been put in a position of being healthcare crisis mental health workers when their job should be protecting and serving in ways that they're trained to do. So if we added the healthcare savings, it would be $10 to $12 per every dollar spent on addiction treatment. So much better use of taxpayer money if we were investing in BUP. So how do those inequities play out for access to BUP, speaking of which? So I sort of touched on it. The Medicaid coverage is, I would say, one of my #1 pet peeves, mostly worse in the Southeast, where Black people tend to live, and yet those states have been the most reluctant to expand Medicaid and tend to have some of the harder issues with things like IV drug use, transmission of HIV and hepatitis C, or overdose, or things like endocarditis. So that's one level of the disparity of access to MAT. Even within municipalities and states where they do have access to MAT, there's a differential in what kind of access. And so I spent many years training and working in New York City, and there's some great studies from there, as well as other municipalities, showing that in the borough of Manhattan, which is more white and more wealthy, that buprenorphine access is much higher than national average. Whereas in the Bronx, which is mostly people of color and Spanish speakers and people either on public insurance or maybe no insurance, that there's a lot more methadone and not so much buprenorphine access. And there's great people working in the methadone world and OTPs. I'm sure there are people on the call who work at OTPs. I love you guys, and I know the science shows that it's effective and can prevent harm and overdose and HIV and Hep C transmission, but it's a different experience for those of you who've seen how BUP works in like MAHEC versus methadone working OTP. It's a very different experience for patients. It's a very different ability to have a normal life and work and take care of your kids. So there's it seems like a simple difference, but it actually contributes to inequity in communities in a variety of ways. And then, I cut out a lot of slides. I hate that I had to, but I was trying to slim it down. There's a ton of examples. Native American communities actually have the highest overdose rates, as you saw in the previous slide, as well as across the country. And, there's a legacy of inequity of, how families are handled with substance use and how kids are removed from families. And the cultural dispossession there. There's, not even talking about race or ethnicity. When you think about rural locations, there's been examples of targeted marketing of addictive substances, specifically oxycodone. There's a great study looking at West Virginia rural counties and the average drive time to OTPs, methadone clinics, versus the travel time to like a dialysis center. So it kind of shows where we invest our healthcare dollars in society. And just a lack of providers, and not just providers for people in rural areas, but providers for a variety of marginalized communities. We know that providers who are people of color have a better time engaging with patients that are from communities of color, and same with LGBT communities. So there's a variety of inequity there with workforce issues, with training and access to medical education. And then, of course, we can't have any slide set, or I can't have any slide set without COVID as part of the story. So COVID has been just a quadruple whammy on people of color in terms of the effect on income generating potential, the effect on incomes and access to healthcare, insurance, access to housing, justice involvement, and how that intersects with race, ethnicity, as well as COVID risk, and then substance use on top of that. So I think that can sort of illustrate why we're seeing some issues with ongoing overdose through this pandemic. So let's end on some actionable steps. What can we do about this? So, so why is this important? Well, one is that healthcare, particularly Western healthcare, is defined as this interaction between me and a person in a room, which is a false paradigm. It is a paradigm, but it's a false paradigm in some ways because really there's a community level aspect to this and really a policy level aspect to this, and that we have to move from the individual choices I make as a healthcare provider and the individual choices a patient makes as a consumer of health-related choices, and move towards the idea of what is the environment? Is it supportive that fosters wellness and health, or is it something that's actively oppressing and marginalizing folks? So we need to think about the pathologies in our institutions that lead to these pathologies that I see in my individual interactions with my patients. But that takes time, that takes relationships, that takes open-hearted discussion that hopefully we're having right now, and takes a commitment to listening to others, and also listening to ourselves. So one way to listen to yourself is the idea of implicit bias. So explicit bias is maybe the more common thought of bias, which is just sort of people who have conscious thoughts that are discriminatory. And there are people like that, but not so many, I would assume. But implicit bias is something every single one of us has. White, black, brown, everyone has some implicit bias, and we should. That's just the way the human brain works to quickly understand things. So I get 20 minutes per clinic visit with my patients generally, and I have to, I have to digest a lot and make quick decisions that sometimes affect someone's life or death risk. And I have to use implicit bias to get there. But there are some ways that can work against me and work against the patient. And so having some awareness of those implicit biases can work towards improving healthcare for those individuals and then for the community at large. So let's talk about ways that we can combat those biases. And this comes from a great article in Family Practice Management. I had the little citation there, and folks can email me if they have questions about any of the citations on this, this presentation. But I'm going to quickly go through. Alan, can you chime in, tell me when I should be shutting up here? It's 10:37 now.
Yeah, we have the next one at 10:55.
Oh, great. Yeah, and I want to save some time for questions, so hopefully I can finish off in 10 minutes. But this is sort of a busy slide. I want to give it its due. And again, thanks to Dr. Ed Goose. I think she's a family doc from, I want to say, University of Wisconsin. So there's sort of three categories here: educate, expose, approach. So educate is about kind of conscious learning and consciously doing things. So introspection is the idea of thinking about your implicit biases. If you Google right now, Harvard implicit bias test or implicit bias training, it's a lot of organizations that do this, but if you want to do this in the comfort of your own home, there are some exercises, there's some exercises you can do that may surprise you. I don't think this works in a vacuum because it can certainly make people think that, hey, I guess I'm biased. I guess I'm a big old racist or a sexist. And so who cares? Maybe I should just live with it. And that's not supposed to be the point, but it is supposed to be so that you sort of think like, hey, I'm not as unbiased as I think. And it kind of ends at the end with that practice culture of humility, which is, hey, we all have the potential for thinking of things in biased ways. And so the more awareness we have that, the better we can do. Mindfulness is a great one. There are some studies, for instance, looking at judges and their sentencing habits before lunch and after lunch. And there's a great, if you just Googled, I guess, New York Times judge and lunch, maybe those words would find it. But it's a great video looking at this study, and I think in Israel, and that lo and behold, judges that convict and sentence people before lunch had harsher sentences than after lunch. And that's because, I don't know about you, but I get hangry every day, and I start getting quicker with my thinking, a little more emotional with my thinking until I've filled my belly. It seems silly, but think about the magnitude of just something so simple. And so mindfulness is just having ways of reducing your stress. And mindfulness practice is one way, but ways of reducing your stress as a method of actually practicing a more equitable healthcare practice or law enforcement practice or whatever work you're doing. So moving on, perspective taking, slowing down individuation is more of ways to understand other people more directly. So perspective taking is things like reading books, listening to music, poetry, movies, documentaries, to really understand communities that you're not familiar with. And really important point is not to rely on stereotype depictions of these folks. It's really easy to do that and say, well, just eat that. Go sit down. One way, I mean, you know, it could be easy to say, oh, well, I listen to hip hop, so I understand the Black community. And please don't think that or ever say that out loud because you'll be laughed at. But it takes a lot of work. And so there are great documentaries out there to understand the experience of someone with a substance use disorder or someone with a history of incarceration. Learning to slow down is sort of building off the introspection. And that's just the idea that once you understand that you have a potential for implicit bias, to actively work to prevent that. So maybe before I go into a room, even though I have this brief summary of who a person is, think about, well, I know from my experience that I jump to conclusions for people who have an alcohol use disorder because my older brother had an alcohol use disorder and I hate him, or I have a lot of bitterness towards that experience. And so I might, you know, treat those patients differently than I might other patients, but having that in your consciousness could help prevent that. And then last in that little section, individuation is kind of finding the common ground. So different perspective taking where you're trying to learn about communities. Individuation is learning about people not really defined by their gender or race or whatever, but really finding the common ground. And so like, hey, you have kids, I have kids. Let's talk about how annoying my 4-year-old is right now trying to jump in my seat and watch the screen. Or like, hey, you like football, I like football. Let's talk about the New Orleans Saints. And that's a way to find that common ground in humanity, particularly for folks where it might be more challenging. And then lastly, approach is sort of moving towards a bigger kind of the macro level interventions we can do. So check your messaging is about not just the words we use. We talk a lot in these OPDAAC meetings of, you know, the words dirty and clean being inappropriate and using like a drug user or druggie or some of those words is not only disrespectful, but it's been shown to affect a person's care. But you can leverage that to the signage we use, the way we have posters in our clinics or in the messaging around COVID has certainly been a great example. So thinking about how we communicate, not just in the public health realm, but even beyond. And then institutionalized fairness is looking at ways of using things like data to understand like, hey, though we understand the rates of opioid use disorder in the state, is my clinic reflecting that? Like, are we doing enough outreach and making this clinic comfortable for patients of those other groups? Are we designing policy to address those inequities? Again, giving a shout out to the next presenters of how we can do that at the organizational and societal level. And then I sort of mentioned the cultural humility, but that's really just none of us are perfect, and there's no intention of anyone being perfect. We shouldn't have that expectation. For me, when I first started getting into work with transgender individuals, I had no training around that as a medical resident or as a student. It just kind of, the work fell in my lap after this one provider retired from this clinic I worked at. And so I made a point of anytime I had a patient like that was different from what I'm used to, I would say like, hey, my number one goal is to take care of you. I'm going to do that the best I can, but I have to be honest, like I'm not really familiar with the experience of transgender individuals. I'm a cisgender individual. I didn't learn a lot about this, so I will probably make mistakes, and I'm not putting it on you to correct me and be my teacher, but I ask for your forgiveness in advance and just know that I'm doing my best to learn. And it was amazing. And I learned this from somebody else back then, but it was amazing the response I got. When I was making mistakes, people, just me as a doctor who's, you know, maybe I have a white coat and I think I'm so smart and I have this power of giving people medications they may need, to put myself at that level and really show how I can show some humility, really did a lot to help me take care of those patients and create a relationship to help them in the future. So, and then just to kind of highlight Black and people of color communities as a particular group that suffers higher rates of incarceration from substance use and poor access to care. There's a great paper that was put out by SAMHSA not too long ago, so you can Google that, it's free. A lot of some of the information I took from the slide set came from them. Maya, back off, please. And then lastly, and this is my way of transitioning to the next speakers, the macro level interventions are really what's needed. The micro will get us so far, but we need a broader approach. So some of that is having a holistic approach to substance use disorders, particularly with these marginalized populations. It's not just about the buprenorphine. We all know that. I know there's a ton of public health people and law enforcement, criminal justice folks on the call. We need to address housing, food security, the ways we approach this at the criminal justice level, living wage jobs. This predicts reincarceration. The police know this better than the healthcare workers know this, that we have to set people up for success if we want to expect them to succeed. The second one there, terribly important, having a diverse stakeholder collaboration. I'm one of those people who I'm often the only non-white person at a table and then expected to represent all the other non-white people, which I can't do. So it's really important that we have a diverse stakeholder collaboration, particularly for those communities who have otherwise been marginalized. So in the Black and African American communities, that's often churches, nonprofits. But I want to underline that law enforcement and the criminal justice system has to be a partner in this. I would just admit that on my end of the political spectrum of advocating for equity, I find that in some conversations, law enforcement and criminal justice system workers are demonized, and that is not a way to make change. Those are folks who are often care about the communities as much as the healthcare workers do, and we have to find new ways of partnering. And I know the state has been championing this with some recent grant funding, actually not recent, for years of doing this. So we need to continue that work. And then again, the people with lived experiences are the ones that know these populations the best, and so they're always important to have at the table. But having this diverse stakeholder engagement is really the key to developing trust and developing relationships with the community over time, which is tough when you have a short-term grant or a short-term worker even, but we have to really look to sustainability through these relationships. And that kind of brings the next one of relationship building and addressing intersectionality, that I, as the one brown person at that table, can't represent everyone. So we need to work on acknowledging people's unique messages and experiences that they bring to a team. And then diverse workforces is not just the stakeholders and the decision makers, it's leadership who might not even be involved. It's the med students, it's high schoolers, it's access to education and opportunities. So all these things I think I saw in some way or another in the task force recommendations. And so I will end there and see if there's even time for questions. I'm kind of a blabberer.
Yeah, I think we have time for questions. First of all, I want to thank you again, Shuchin. You're always generous with your time and your wisdom. I know you're given a college course in a fraction of a morning, so I appreciate it. You've covered such a wide body. And I was going to say, I know you got a helper there. If you feel like introducing your helper, go ahead.
Oh, and I'm on a mic, but Maya, do you want to say your name? You don't want to say anything? Do you want to talk about your apple? I guess not. Well, she's finally quieted down.
we all
I don't know if y'all heard her singing.
I think many of us are experiencing what you just experienced. But I think Amanda and Margaret are monitoring the questions. Anything you want to bring up from the chat? Or anybody want to add anything into the chat now in the few minutes we have for questions? I think we had one chat go through that wants to follow up on the MAT methadone conversation, which is fine. Amanda, anything to raise?
I don't see anything coming through, just praise for you, Shuchin. Just a reminder, if anyone has any questions, we've got a few minutes to put them in the chat box.
I'll ask a question.
Sure.
I think the one that has come up as a theme throughout our OPDAAC work is we've started this body of work with the medically prescribed opioid epidemic, but we have a generation that's experienced the effect of war on drugs. And I know that there's a racial equity part of that. I think Steve and Jasmine will discuss that. But any comments or just like how to fit that into the conversation about folks that have been affected with the war on drugs and in this new generation of addressing substance use disorder?
Yeah, I mean, I read through Steve and Jasmine's slides and then took some time, thanks to Anna pointing out to me the the full, like at least the executive summary of those recommendations. I mean, all that sounded perfect. It sounded hard. I'm not a policymaker yet, but it sounds like it's going to take a lot of work and a lot of political capital and goodwill and funding to achieve a lot of those recommendations. So I think having that task force is a great start, and having conversations like these. And I find myself often talking to audiences where I feel like I'm preaching to the choir, if you guys know that phrase. And I think I want to move away from that and move more towards talking to people who are different from me and finding ways to communicate. And so I think that's something we all need to do, and find some common ground, right? We just came from a tough election. I'm going to venture to go political, and a tough couple of years where there's been a lot of division, and it's present in healthcare. I see it in the stress and anxiety and substance use of my patients. And I think it's going to take some years of recovering and finding new ways to communicate. I hope I'm not getting too wishy-washy. I'm used to the hard science, and I don't think we have a hard science for how to, recover from division, but that's something that's got to happen.
Thank you. I think you gave a good example of how to address the humility in your comments about transgender, just opening and saying, I don't have experience in here, help me out. I think that's a really good, insightful skill to say. We're all presented with folks that are different than us, and sometimes not addressing the obvious, that I don't know how to navigate this conversation and I don't want to be offensive.
Yeah, and I would encourage, I still remember my first anti-racism workshop that I did in New Orleans right at the end of med school, and it changed my life. I mean, I'll just drop that and drop the mic, but there are a variety of organizations. We certainly do like a multi-hour version of what I just did through MAHEC, so people can contact me or contact folks from MAHEC to set that up. But there's a bunch of organizations. Visions is one, and Racial Equity Institute is another. Bunch of organizations in North Carolina and beyond that do great workshops, and it's the hard work, but that's a great way for individuals to kind of take the next level and learn how to engage in this topic. So that would be my last kind of recommendation for individual people.
Well, thank you so much.
Hey, Alan.
Yeah.
There's one question in the Q&A that I wanted to raise, Shuchin, if you've got time. Do you have any thoughts or information concerning racial disparities amongst youth in the justice system? Have you noticed any trends pertaining to substance misuse?
Yeah, I mean, I've seen statistics about differential punishment, for instance, and I think Steve and Jasmine may have better answers to this, but I know there's differential punishment, for instance, by school resource officers between races, and even like I know in Buncombe County, there's differences in suspension and expulsion rates between races in high schools, and we use that term. The school to prison pipeline. I think it kind of starts there. I can't speak so much to substance use disorder. I think just broadly in pediatrics, right? And that's what we say in healthcare adolescents. I think there's a great study, and I'd have to dig it up, but like there was a study looking at teens that went to the ER after an overdose, and then the likelihood that they were prescribed MAT after that event was like less than 10% or something. So I think just pediatrics and adolescents specifically are their own marginalized group when it comes to substance use disorders. But when I think of the ACEs and how ACEs affect children and teens of color versus non-teens of color, there's a great differential there. And those ACE studies, the majority of those were all done, I think, in the Kaiser Permanente population. So it's mostly insured middle-class white population. So it didn't even account for the trauma and stress of just having different skin color in this country. So I think there's like more study to do, but certainly from what we know that there's some changes we can do to how we address substance use and even like, the things that get you suspended and expelled in school. And I think there's a slide that Steve and Jasmine have about school resource officers. So I defer more to them.
Thank you. I think we're at time. So I really, again, appreciate the generosity of your time and wisdom. I'll say for those that have been in the body of work that we're doing with the OPDAAC, one of the themes for our opioid summit in the first week of May is we'll continue this conversation. So hopefully you'll see this won't be the last time we'll have this conversation. It's part of the body of work that we're working on now. So thank you again. Have fun with your daughter. Take some time. Turn it over to Anna Stein.
Great, thank you. And I do want to take this point of privilege to address Mary Ward's comment about opioid treatment programs and talking about Shuchin's pointing out the study that African Americans sometimes have less access to buprenorphine treatment. And so I just wanted to say that I think Shuchin would probably agree, and I would certainly agree, that methadone treatment is not in any way inferior to buprenorphine treatment. It's a wonderful treatment, but that everybody should have access to what works for them, which could be methadone for some people, could be buprenorphine for some people. So I think the study was showing a lack of access of African Americans to buprenorphine treatment. Not that the methadone treatment was inferior, but just the lack of access to that type of treatment, and that everybody should have access to both. So thank you for that comment, Mary, because I wouldn't want anyone to think that we were disparaging methadone treatment. And now I want to turn it over to this wonderful conversation on the governor's task force on racial equity and criminal justice. And I am super excited to introduce Jasmine McGhee and Steve Mange. Jasmine is special deputy AG in charge of the public protection section of the Department of Justice. And Jasmine has been the lead of this task force. I mean, of course, there are the leads of Justice Anita Earls and Attorney General Josh Stein, but I mean, the true lead of this task force is Jasmine McGhee. And the amount of time that she has put into this and working with stakeholders in an incredibly complicated subject matter area is absolutely phenomenal. And then Steve Mange is the Senior Policy Counsel for the Attorney General, and he is the point person on all things opioids and drugs. And Steve was really helpful, I know, in looking at the marijuana portions of this platform, and really helped bring in a public health perspective to the conversation, which I really appreciate. So I'm going to turn it over to Jasmine and Steve, and thank you for joining us.
Thanks.
Thank you. Thank you so much for having us. We're really excited to be here. Steve, I don't remember what we figured out regarding the advancement of the slides. So I'm just going to ask you.
You just say next slide. You or me say next slide. And our friends at the at the Governor's Institute, Alex, I believe, will advance the slides like magic.
Awesome. Okay. Okay, I can work with that. Thank you again for having us all, having us here. Can we go to the next slide, please? I think we all know how we got to this moment, but I think it's important just to set the stage that while we were dealing with the pandemic of coronavirus, we were once again confronted with a pandemic that we've been dealing with for much longer, and that's the pandemic of racism and the way that intersects with our criminal justice system. And I was really honored to be asked to work on the Governor's Task Force for Racial Equity and Criminal Justice, which the Governor created by executive order in June of 2020, and asked the Attorney General to co-chair along with Justice Earls. If you could go to the next slide, please. And one more. And one more. The executive order created the task force in June, as I said, and had a number of different stakeholders on it: advocates, elected officials, judges, prosecutors, public defenders, and law enforcement. And it really allowed a lot of different perspectives to be heard as we had this conversation. And it was very clear early on that everybody had the same goal, and it was just important to be able to come together and have these conversations. And I think because criminal justice, I mean, North Carolina has a history of working on criminal justice reform issues, as this group knows, but not necessarily with a racial equity lens. And that was one of the things that was different about this work. And it was really exciting to be able to have those conversations with such a wide range of stakeholders. And in fact, the task force went through racial equity training together as it set the stage for the work that it had to do. Go to the next slide, please. We heard from a lot of stakeholders and listening sessions where they were smaller groups of relevant stakeholders, and then we had 3 different public comment sessions. And now we are going to jump into some of the recommendations, and I'm going to turn it over to Steve to talk about some of the ones we tried to, obviously, if you go to the next slide, cull some of those that are most relevant to the work that this group works on, but happy to talk about any others if folks have questions. And I know we're going to, try to go through these as quickly as possible so that we can leave time for questions. So I'll turn it over to Steve.
Thank you so much, Jasmine. And Jasmine, just to add, thank you so much for your hard work on this task force. It was amazing to see what you and the team and me tangentially on a couple topics were able to accomplish. So as Jasmine said, we're going to run through these strategies pretty quickly and hope that you all have questions to ask. And so what is interesting about the work of the task force is that there is so much intersection with the work of OPDAAC and the work of so many advocates who have been trying to address the problem that we see in this intersection between substance misuse, mental health disorders, and the criminal justice system. And I think the broad sentiment among probably everyone on this call today and everyone who's been working on this issue that all too often the criminal justice system is asked to address issues that it's not really qualified to address, certainly not best qualified to address. And so there's many common themes between what we're about to talk about and what we all have been talking about collectively since I came to the Attorney General's office almost exactly 4 years ago. So the first recommendation that we want to talk about is the recommendation that we find ways to respond more appropriately for calls for emergency service, because in many, many instances, some of the tragic and unfortunate outcomes that we have seen have been not only at times the result of racism or poor policing, they have also been the result of us as a society asking police to do things that they're not qualified, not the best qualified to do. And so there's many innovations out there. For example, there are co-responder units like the one in Chapel Hill, where trained police officers go with trained mental health and substance use professionals to respond to certain calls. There's other models out there, such as the Cahoots and the STARS model out west, where there's a team of professional social service workers who are able to respond to calls that may not even require police officers to be present. Next slide, please. One of the other recommendations was that all police officers should be trained, should have crisis intervention training just as a basic part of their basic law enforcement training, because so often they're responding to situations that involve people in some type of mental health crisis. Even if many police forces will have a unit that may be devoted particularly to responding to those, but we do feel like there should be a baseline understanding among all law enforcement of some of the basic, sort of this basic understanding and basic techniques for responding to behavioral health issues that they encounter. Next slide, please. I think we're back to you on this one, Jasmine.
I think so, and I just picking up on the theme that Steve was talking about regarding crisis intervention. We heard a lot from folks in the public health field about, and from the law enforcement training field about the understanding that there's a difference between a crisis intervention officer and someone who has crisis intervention training. And we really tried to make that distinction, and that the bare minimum should be that everyone should have that training. But even still, if you're not going to go with a co-responder model, or you're not going to go with a Cahoot sort of non-law enforcement response model, that you do try to have those units that of specialized officers that you can send out where possible. We understand that's a funding issue. There are a lot of challenges associated with that, but we felt it was important to be able to state out loud what the best practices ought to be. And that really we are trying to de-emphasize the role of law enforcement in some of these responses, and law enforcement frankly, it has been in support of that concept in theory. And we think there's a lot of synergy around that concept. Similarly, this recommendation, and there were a number of sort of funding community organization type recommendations, and I wanted to pull this one out in particular because understanding that there are a lot of community organizations that are doing work, particularly in the substance use arena, in the violence prevention arena, trying to think about different types of interventions that may be helpful. And so as we think about that sort of government-led sort of stool, both social services and law enforcement, that we also think about community partners. And so that was one of the recommendations that we thought was relevant to this group. Related, the recommendation of forming community safety and wellness task forces. Durham was a model here. This is something that they are just standing up now. And the idea, again, you see a theme here of communities determining what responses they want to have to community safety problems that don't involve law enforcement. And so allowing that conversation to take place in a way that isn't focused on the criminal justice system, but is focused on safety and wellness. It's a very new model, but is one that that the task force found was interesting and intriguing, and want to follow the development of how that work goes in Durham and perhaps introduce it to other communities as something that can be helpful as a part of their toolkit. Steve, I'll turn it back to you.
All right, next slide. Yes, so this really underscores something that we all, I think, probably agree on, and that I stated earlier, which is simply to recognize that addiction is fundamentally a healthcare and a public health issue, not a criminal justice system issue. And that, as we have said, the criminal justice system is often the least equipped institution to deal with many of these problems. And so this was broadly recognized by the task force. And that led to some more specific recommendations. Next slide, please. So one of the very specific recommendations is to support diversion programs, both pre-arrest and post-arrest, where we try to get folks whose fundamental issue is an addiction or behavioral health issue, not that they are criminals, to get them the help that they need. And so this is a recommendation I think would be very near and dear to many folks on this call who have been working on these, such as the LEAD model that the Harm Reduction Coalition has been so instrumental in helping establish throughout the state. Another really helpful practice that some departments do already a great job of is encouraging citations and summons in lieu of arrest, particularly for misdemeanors, where you basically are sparing the person the disruption and indignity of an arrest, where they can be simply given a summons. And so in both of these and in many other recommendations, a key issue here is the equity lens. I think a comment that I think many of us recognize as being true is that the expanded interest in things like pre-arrest diversion programs has been very much a result of the opioid epidemic, and quite candidly, the fact that the opioid epidemic has affected a much broader array of races and classes and members of the population. And so one of the things that Jasmine and I and the Attorney General are clear on, and one of the things that the task force is clear on, is that to the extent that we are promoting these welcome innovations in criminal justice, they need to be done in an equitable way. So that would mean, for example, not having LEAD programs focus solely, for example, on opioids, but having them focus on all substances of abuse to ensure in all populations, and to keep good data on the clients that they're serving to ensure that the benefits of these programs accrue to everybody, all races, all classes, all people. I think next slide goes back to Jasmine.
Yes. So we had a robust conversation around the role of the school resource officer. There are a number of recommendations in the report around this issue. The one that I wanted to pull out and highlight for you here is the recommendation that had unanimous consensus, I believe, about the need to hire more behavioral health professionals in schools. Again, with that same thinking that we're asking people who don't have the training to serve a lot of different roles, and interventions that would help kids early are not necessarily happening, and they are ending up in the juvenile and criminal justice systems when they need not be there. Secondly, there was a recommendation related to, again, training school personnel to meet those needs, even when they're not the best equipped to necessarily do that, but certainly similar to law enforcement, putting folks in the best position to be able to engage students and kids in an effective way that diverts people from more punitive responses to childhood behavioral problems. There is another recommendation that if you go to the next slide, related to studying the connection between physical and mental health on job performance. Again, given you all's interest in issues of substance use and public health, I thought that this would be one of interest. The task force thought that as we're throwing the kitchen sink at this problem, we need to understand what factors contribute to job performance, perhaps improper use of force. And, I think this is another area where, officer wellness is something that law enforcement cares a lot about as well. And so we thought it was a good place for consensus to try to understand what connections there might be between these two things. If you could go to the next slide, I'm gonna turn it over to Steve to one of the recommendations that was his baby through this process.
Thanks, Jasmine. We spent a lot of time looking at the issue of marijuana decriminalization or legalization, a very controversial and difficult and vexing issue. And the thing I just want to point out to those on the call, and I believe this came up during the earlier presentation, is there is a massive, first of all, there's a massive amount of charges and arrests for even just small possession amounts of marijuana. So for example, in 2019, there were 31,000 charges and 8,500 convictions for just the smallest possession amount of marijuana, just merely up to a half an ounce, like a joint or whatever. And here's the kicker: 61% of the charges were against non-white people, despite the fact that they are a minority of the population and that usage rates of marijuana are roughly equal between white and black. And so there's a huge disparity here that needs to be recognized and addressed. And the way the task force, after much study and deliberation, decided to do this was essentially kind of a two-step approach. The first step being to recommend decriminalization, not legalization, but decriminalization of possession amounts of marijuana. And what that essentially means is you're talking about it being a civil offense, like a traffic ticket, instead of a criminal offense with all the terrible consequences that follow. And so the second part of, and along with that, and critically, you would want to have a process, an automatic process of expunging past convictions, because that's literally tens or hundreds of thousands of people charged with really small amounts of marijuana. Next slide, please. And the second part of the equation is to really take a long, hard look at the issue of legalization of marijuana, because quite candidly, it has the potential to have huge upsides, particularly on the issue of racial equity. But there are potentially huge public health downsides as well. We really don't want to encourage youth use of marijuana. We don't want to encourage big marijuana to take over the way big tobacco has taken over. There's just all kinds of downsides to legalizing if you don't do it the right way. And the good news is there's a lot of different ways to legalize. There's issue, whether you're talking about possession, cultivation, sale, it's a complicated question. And so the recommendation is to set up a task force to study legalization and try to come up with the best way of moving forward, recognizing, it does seem to be the wave of the future if you look at what other states are doing. In that respect, folks might be interested in looking at what the proposal that's now pending in Virginia, which was the result of a similar task force and has some, I think, promising elements to it. Next slide goes back to Jasmine.
So this issue of bail reform is one that our office and the Attorney General was pleased to see be supported by the task force. It's an issue that we have been working on across the state and been doing a number of convenings around the issue of bail reform that were interrupted by the pandemic. The task force recommended a number of things in the bail space. I put a few of them here, but want to pause on the last one. The first one is really elimination of cash bail on low-level charges unless there is a risk to public safety. The law in North Carolina already disfavors financial conditions of release, and yet we see that financial conditions are commonly set across the state, even on very low-level charges. The second one is related to first appearances and providing counsel during those first appearances for misdemeanor cases. That's already a requirement within 96 hours for felony cases, but misdemeanors can often languish for weeks before their first court appearance. And this is something that's happening in a number of places. I think most relevant to this group is this recommendation regarding the use of pretrial services at no cost to the defendant. And that's because we have seen in numerous jurisdictions across the state that at the pretrial period, using the sequential intercept model, there are a number, that's one of the places where folks can get the services that they need, not only to have successful pretrial outcomes, which is the goal of those programs, but also to help themselves. And so we think that's a really important piece. It's going to be a challenging piece because that, like the recovery courts, is not a place where the state has been a funding source. And so counties have done their pretrial programs in a number of ways, most of which end up requiring county funding. And that's obviously a challenge in some of our less resourced counties. We're very interested in whether regional pretrial services models might be accomplished, and expect that'll be a place where the task force wants to spend a lot of time and welcome the opportunity to partner with folks who are working on that issue. Next slide, I think, goes back to Steve.
Hey, Steve, it's Alan. Just
Yes,
want to
sir.
give you a time check, about 10 minutes.
Great. Yeah, I think we're actually very close to the end. So I'm optimistic there will actually be a few minutes for questions as well. Thanks, Alan. So this is another one that I think is really intersects heavily and is near and dear to many of the folks involved in OPDAAC, and that is the idea of increasing funding and support for behavioral health services and programs in prison. I think many folks here are familiar with the tremendous efforts of DHHS, Durham, Buncombe, several, New Hanover, several other counties to get medication-assisted treatment programs going in jail. And I see Margaret's on. I know she's been involved in that, as well as Amy and others. But obviously, the recommendation here is, of course, broader than that, because it's not just MAT that we need. It's a whole host of behavioral health services and programs, and a really determined philosophical focus on rehabilitation, mental health, and community connection, which is just very consistent with many of these programs that we've been collectively supporting over the last few years. Next slide.
And I'll just follow up on Steve for a moment. I'll say one recommendation we didn't include, but was sort of triggered for me in the way that Steve explained that one, is the recommendation that people be at incarceration, people be screened for victimization and provided trauma services. And I think that very much ties into some of the behavioral health challenges that people may be struggling with. And so, really calling out that point of the sort of trauma history that people who may be incarcerated have was really important to the task force as well. So we submitted this report, which was much longer than this presentation of 125 recommendations on December 14th. And we are just this week starting committee work to work on implementation of the task force recommendations, working on a legislative agenda, working on implementation through executive action, executive agencies, judicial branch action, local policy action. The task force will also have committees focusing on public education and communications, and then a study and data and evaluations committee. So that's what we're going to be doing over the next 2 years. The executive order had us in existence until the end of 2022. And we look forward to partnering with you where it makes sense. If you could go to the next slide, it has, I believe, the website for how you can keep up with what is going on in TREC. I will also put my email and that of Ellen Spoler, who is our project manager, in the chat. Feel free to reach out, and we really look forward to working with you. Questions? Don't know how we're handling questions.
Anna, are you facilitating this portion?
I can, Alan.
Oh, okay.
Yeah.
Well, I'll let Margaret do it. Thank you, Margaret.
No problem.
Margaret to the rescue again.
I am here.
It's a theme.
Yeah. So the first question is the 1.5 ounces that you guys referenced to traditional marijuana liquid or edibles?
You know, I don't know that off the top of my head. I do. So let me just not pretend to know something I don't know. If someone wants to shoot that to me in an email, I'd be happy to respond by email. So anyone can email Anna, Alan, or Margaret, and they can forward it to me or whatever. And I will definitely research that and get back to you.
The only thing I can say is it was certainly intended to be all of the misdemeanor levels of marijuana possession, because that was a part of the conversation at the task force.
Thank you both. Let's see. The next question is also related to the 1.5 ounces, but is how does this apply to adolescents, as I did not see an age restriction on the application of the decriminalization of the specified amount? Will therapeutic interventions be the mode of operation with adolescents, or has that been explored?
I think those details have not been hammered out, quite candidly. I think a lot of the details remain to be hammered out. So I don't know that question has been answered yet.
Sure. But certainly consistent with the full report, we are not trying to do anything that would have bad public health consequences, and sort of the inclusion of diversion recommendations elsewhere in the elsewhere in the report suggests I think the task force would be supportive of implementing the decriminalization in a way that is public health focused, but doesn't have the criminal consequences for folks that flow from arrest.
Thanks, Jasmine. And we have another question in the Q&A, and then I'll move to the chat. What recommendations do you have in regards to addressing the issue of insufficient staffing in criminal justice agencies, especially in rural communities with significant substance misuse and accidental poisoning rates?
Sure. There were, and I can follow up as Steve will with the specific recommendations, but there was a recommendation related to enhancing DPS personnel in particular to be able to more effectively respond to the needs of incarcerated people. There were a number of recommendations related to increased service, increased funding. I went over one related to the mental health professionals in schools, but I think the recommendation related to reimagining public safety and emergency calls for service certainly speaks to that question. I think as a whole, we recognize the need to sort of professionalize and provide the resources to our agencies to be able to more effectively respond to public health challenges. I think that the task force is wary of assuming that those responses need be criminal justice focused. But while the criminal justice system is doing its work, it needs to be adequately funded to do so. Hope that's responsive, but if there are, I can also point to specific recommendations if someone wants to follow up with me.
Thanks, Jasmine. Did you want to add anything to that, Steve, or can I move to the next question?
Next question.
All right. Were there any recommendations related to implicit bias training for law enforcement?
Yes, all the recommendations. Everybody, everywhere. Law enforcement, court system actors, victim compensation, employees, juries. There were a number of different racial equity training recommendations.
And there's more discussion around the concentration of the liquid marijuana and around that 1.5 ounces, but I know you guys said that you will attempt to address this through email at a later time.
Yeah, I'm not familiar with the concern. I see in the chat, it's a big concern. I'd love to learn more.
So here's another one. This attendee says, thank you kindly for the update on the recommendations. Any word on encouraging the governor to utilize commutations and pardons to reduce the populations in prisons, particularly in response to COVID?
Sure. So it sounds like based on that, you're familiar with the fact that there were recommendations related to commutation. They just very quickly, for folks who might not be aware, there was one that focused on additional funding and staffing for the clemency office to focus on COVID-19 related releases, and also people who may have been released if they were sentenced under pre-structured sentencing but are still serving their time. There was one related to juvenile cases, clemency in those cases, and also a recommendation related to clemency initiative similar to Obama style clemency initiative that would identify particular cases for the governor's office to study. The governor obviously has been paying close attention to the task force, created it himself, has one of his policy folks as one of the co-leads along with me on the task force, and is taking a close review of all of the recommendations. And you may have seen in December, took some clemency actions, and my understanding is that he is interested in taking more, and I don't have more detail than that. But I think that the governor recognizes, as he said in his reaction to having received the report, that he's one of the actors in the system and wants to be a part of the solution, as we are asking law enforcement and local governments and the legislature to be as well. And so, yeah, I think that's my answer.
Thanks for that answer, Jasmine. I know we're getting towards time, but I thought that this question was really important, and it ties back to something Dr. Shukla mentioned around the social determinants of health. And so this question is about the fair housing law and discrimination against those with a criminal record. To the attendees' understanding, it is that if you have a substance use offense for distribution or another offense, you are not covered under the fair housing law. Do either of you know if this is true?
I don't know. I mean, collateral consequences was an area of study. We had a lot of areas of study. And so the recommendation that most closely ties to this issue is related to SNAP benefits. The task force recommended that the legislature act to not restrict people from using from SNAP benefits if they have certain drug convictions. The task force also fully supported all of the statewide reentry council collaborative recommendations. I don't recall a specific housing and substance use recommendation, but I'm happy to talk about that and follow up.
Yeah, feel free to send us an email on that. We can research it.
Mm-hmm.
Thank you both. And I don't know, this is kind of self-serving, but I know that Steve is text this from me, and we had another question. What do you see as the role of syringe service programs in your recommendations?
Well, I mean, I think we know from all of the hard work of many of the people on this call, and from much of the data that's been collected both in North Carolina and nationally, that syringe service programs are an essential component of this broad effort to treat addiction and mental health conditions as a public health and a healthcare issue rather than a criminal justice issue. And so I think in that very broad sense, While syringe service programs were not a specific recommendation here, they certainly fall very squarely within the broad philosophy that is endorsed by the task force, again, to treat these issues fundamentally as public health and healthcare, individual healthcare issues, rather than criminal justice issues.
Thank you. I think we're about at time here. So I want to thank again our presenters, Steve and Jasmine and Dr. Shukla. I hope folks appreciate this is part of an ongoing dialogue. This depends on how you look at the substance abuse and opioid epidemic. We're trying to create a place to have a conversation. The policy work is tough because we're looking for change. And Steve I couldn't believe it when you said 4 years almost to the day. Steve has been such a partner over the years of trying to do what he just described now with Jasmine, get a good group of people together, hem it down to things that we think we can get done, and then move towards making some change. We live in a world that's fixed with, this is how it is. We change by talking to each other and learning from each other. So you put that link at the very end for folks that get inspired by what they hear. Maybe summarize real quick, what's the body of this task force going forward now that the recommendations are made? Are there ways for folks to participate or contribute or comment?
Sure. So we on that DOJ/ncdoj.gov/TREC page, there's a public feedback form that you can always use. I did put my email in the chat as well. Ellen Spolen and I are always happy to talk with folks. The task force is going to be meeting on a quarterly basis going forward. Those meetings are going to be on our YouTube page, youtube.com/NCAGO. But that meeting schedule is on our website as well. The committees will be meeting on a monthly basis. We're not streaming those, but there's a number available for folks to listen in if you want to keep up with what we're working on. Lots of conversations like these, lots of smaller ones as well, to really try to get as many stakeholders on board with the various implementation strategies that the task force has. And I mean, I think, as much as I would like to wave a magic wand to the extent one can at the legislature to make all of the things happen and have all of the things be funded, I think we're very aware of the fact that a lot of the work is on the ground. It's going to continue to be on the ground. It's going to continue to be at local jurisdictions, and it's going to involve grant funding, and it's going to be a slog, but we're committed to it.
And just to piggyback on that, as the sort of opioid point person, if there are particular topics that we covered in this sort of fire hose of a presentation that you want to revisit, whether it's through OPDAAC or through the May Prevention Conference or through some separate means, Jasmine and I can't even count the number of things we've co-presented or co-taught, but we are always available to come back to future meetings, convenings, committees, task forces. We're gluttons for punishment. So count us in.
Thank you. So I think we'll have to conclude here. Thank you again for everyone's generous time and the team behind the scenes to present the session. You'll be seeing an email coming out about a session in March on the impact on pregnancy in the opioid epidemic and substance abuse work. You'll also see a registration link coming out pretty soon for the May 4th through 6th summit. Active group of folks working on the agenda. And this session will be up on the PowerPoint slides as you see. So thank you again. Have a great weekend. It'll be a beautiful day today and cold tomorrow. So enjoy a little of the afternoon and see you later. Bye.
Thanks, everyone.
Bye.